Good morning, ladies and gentlemen. Today is part 2 of my lecture on cutaneous photosensitivity diseases. In the last lecture, I discussed three important primary photosensitive diseases, that is polymorphic light eruption, juvenile spring eruption, and actinic prurigo. So in this lecture, I am starting with chronic actinic dermatitis. Chronic actinic dermatitis is a persistent or recurring dermatitis predominantly affecting the photoexposed sites in association with objective evidence of photosensitivity. The photosensitivity is usually to broadband, predominantly UVB wavelength. And the term chronic actinic dermatitis encompasses 4 previously reported diagnoses, that is the actinic reticuloid, which describe the pseudolymphomatous infiltrate, a photosensitive eczema, a photosensitivity dermatitis / actinic reticuloid, and persistent light reactors. So all the 4 different categories of diseases now comes under one diagnosis, that is chronic actinic dermatitis. Incidence and prevalence. CAD or chronic actinic dermatitis occurs worldwide, although it is commoner in temperate climates. CAD is second most commonest idiopathic or immunological photodermatitis after polymorphic light eruption. Estimated overall prevalence is 1 to 5 per 10,000 cases. It typically occurs in elderly people and mainly in males with age between 60 to 62.7 years. Although onset in younger age is described, and this is commonly associated with atopic eczema. Male to female ratio is 2.6 to 7.1 to 1. And this can occur in all the skin phenotypes. Pathophysiology. This condition is thought to be an immunological disease, and it is supported by association with contact or photocontact allergy, atopic eczema, response to immunosuppressive drugs, and HIV. The existence of prolonged prodrome, such as atopic dermatitis or allergic eczema, before the development of photosensitivity suggests a requirement for persistent T cell activation to trigger the photosensitivity. Light exposure alone appeared to be sufficient as a trigger. The most plausible hypothesis is of delayed type hypersensitivity reaction to unknown endogenous photo-induced antigens, similar to the mechanism in allergic contact dermatitis. Similar to allergic contact dermatitis, there is predominance of CD4 positive T cells and upregulation of addition molecules E-selectin, VCAM1 and ICAM1 and interleukin 1, 6, and 8. Pathology. Histology of chronic actinic dermatitis is not specific. Epidermal spongiosis, acanthosis, and upper dermal perivascular lymphohistiocytic infiltrate usually occur in acute cases. Eosinophils, plasma cells, atypical large hyperchromatic and convoluted nuclei, and mitosis may be evident, and Langerhans cell can be increased as the disease progresses to chronicity. In actinic reticuloid, there is epidermotropism and atypical lymphocytes, and hence it is difficult to differentiate it from mycosis fungoides. The only clue here will be solar elastosis that would be seen in the upper dermis. So the changes in chronic actinic dermatitis ranges from changes of chronic eczema to changes of T-cell lymphoma. So here you can see that there is dense perivascular lymphohistiocytic infiltrate, acanthosis, and hyperkeratosis. While as the disease progresses from dermatitis to lymphoma, then there is epidermotropism and with presence of large atypical lymphocytes. Clinical features. The classical features are of pruritic, recurrent, or persistent dermatitis predominantly affecting photoexposed sites and worse in summer. Some patients are not aware of the association with sunlight exposure because it's a chronic accumulative damage by sunlight. Most patients have a history of atopy, contact allergy, seborrheic or endogenous hand eczema, often over many years, and it may be difficult to pinpoint from the history when photosensitivity began. Presentation can be acute or chronic. In acute phase, there is eczematous, exudative vesicular dermatitis on photoexposed sites, and in chronic phase, lichenification and pseudolymphomatous infiltrative plaques are seen. So here you can see diffuse erythema on sun-exposed areas, sparing the area under the eyes, and there is diffuse thickening of the skin with slight leonine facies. In patients with the skin phenotype 4 to 6, there can be nodular prurigo-like morphology, and the lesions are associated with alopecia, ectropion, hyper and hypopigmentation, which can appear vitillaginous. Examination may show prominent involvement of photoexposed sites of the head and neck and limb, and there is lack of involvement of non-exposed sites with sharp cutoff. In one study, 44% present with covered site involvement and 15% with generalized erythroderma. And patients also have concurrent Palmer or plantar dermatitis that occurs in 15%. So here you can see the chronic prurigo-like lesions, mainly on the hands and face, and sometimes it extends to the trunk. The differential diagnosis of chronic actinic dermatitis involves the airborne contact dermatitis that typically involves the upper eyelid, nose, chin, while the back of neck is spared. Photoaggravated atopic or seborrheic eczema may be impossible to differentiate or distinguish from chronic actinic dermatitis on clinical ground. Then drug-induced photosensitivity and cutaneous T-cell lymphoma, especially if there is erythroderma. The disease course and prognosis. There is generally symptomatic improvement due to light and allergen avoidance. And if UVB photosensitivity is severe at the diagnosis, there are two or more separate contact allergens, there is poor prognosis for the resolution of photosensitivity. So in the absence of erythroderma, life expectancy is normal, and there is no evidence of increased risk of lymphoreticular or other malignancies. But if erythroderma sets in, then the risk increases. Investigations. The main investigation is phototesting. Monochromator phototesting to UV ultraviolet and visible wavelines across the solar spectrum is the investigation of choice. Patient or prednisolone may affect the result of phototesting. Abnormal erythemal response assessed by minimal erythema dose at each waveband is tested and will be most apparent after 24 hours of phototesting and will become a dermatitis. If minimum erythema dose is abnormally low, then CAD should be suspected and monochromator photo testing should be performed. Most patients with chronic actinic dermatitis have predominantly UVB sensitivity, although many will also have UVA and visible wavelength involved. So 100% have UVB involvement, 88% have UVA as well, 59% at 400 nanometer and 26% at 500 nanometer of visible wavelength. Patch and photo patch testing. Patch testing is an essential investigation in patients with suspected chronic actinic dermatitis. And photo patch testing can be helpful when practicable to perform. Allergens, often multiple, include fragrances, rubber additives, nickel, colophony, medicament, and sunscreens. Plant contact allergy in chronic actinic dermatitis is very common, notably to Asteraceae, composite lichens, and oleoresins. UV-absorbing sunscreen chemicals such as benzophenones, dibenzobenzyl methanes, and octacrylene are most likely culprit, but this allergen profile changes with time and exposure patterns. The test is difficult or impossible to undertake and interpret in patients with significant photosensitivity. In drug-induced photosensitivity, there will usually be predominant UVA sensitivity in patient taking photoactive drug, and morphology of eruption is not eczematous. You know that the UVA sensitivity is primarily UVB in chronic actinic dermatitis. In erythrodermic chronic actinic dermatitis, Sézary syndrome, T-cell lymphoma need to be excluded, and photo testing in later if feasible is usually normal. Cutaneous lupus and porphyrias generally do not present confusion, and these two can easily be excluded. Management. If patient is taking a photoactive drug such as thiazide or quinine, it should be stopped, and if feasible, repeat photo testing is undertaken after 3 to 6 months. Management involves the prevention of flares and suppression of active disease. Careful avoidance of ultraviolet radiation and, when necessary, visible light by photoprotection using hat, clothing, education, and high factor, broad spectrum, non-fragrance, low allergic sunscreens. Watching television, using computer, artificial lighting exposure are not a problem for most patients, although the introduction of compact fluorescent lamp which emit more UV light can pose a risk. Patients should be aware of need to optimize dietary vitamin D intake and, if necessary, take supplement. First-line treatment of established disease involve a very potent or potent topical corticosteroid. Second line include topical tacrolimus or pimecrolimus, systemic glucocorticoids in acute flares. PUVA may also be effective if tolerated. UVB phototherapy may be effective but is usually not feasible because of degree of UVB photosensitivity. Phototherapy or PUVA often requires systemic glucocorticoid cover in early stage to prevent the disease flare. Third line include immunosuppressives like azathioprine. Dose can be 150 milligram a day and can be used as a steroid-sparing agent. Other agents include hydroxychloroquine, cyclosporin, mycophenolate, mofetil, etretinate, thalidomide, infliximab, and interferon alpha. Then the fifth disease I'm going to cover today is the solar urticaria. Solar urticaria can be primary, idiopathic, or secondary to drugs, chemicals, porphyria, or lupus. Idiopathic solar urticaria is an immunological photodermatitis based on type 1 or immediate hypersensitivity to poorly defined photo-induced antigens. It is characterized by immediate development of urticaria following exposure to ultraviolet A, visible and less commonly UVB radiations with resolution occur within an hour or so. Incidence and prevalence. Idiopathic solar urticaria is uncommon, representing 2.2 to 17.8% of diagnoses, with lower figures seen in patients with higher skin phenotype type 4 to 6. Estimated overall prevalence is 1 to 5 per 10,000. Peak incidence 3rd to 5th decade, more commonly in female, and it coexists with other type of urticarias and with other photodermatitis like polymorphic light eruption, chronic actinic dermatitis, and actinic prurigo. And there does not seem to be an increased prevalence of atopy with solar urticaria. Pathophysiology. Idiopathic solar urticaria may in some cases be allergic type 1 hypersensitivity response, mediated at least in part by histamine and other agents. The proposed pathway is likely that of photochemical alteration of an endogenous chromophore by ultraviolet radiation or visible light resulting in an antigen. This is then recognized by a specific IgE with subsequent mast cell degranulation and histamine and other mediator release. In secondary solar urticaria, the drug or porphyrin presumably act as the chromophore. Provocation wavelength vary between and within patients. Mechanisms of photoaugmentary and photoinhibitory wavelengths are poorly understood. Histamine is implicated since antihistamines are at least partially effective in most cases. However, other mediators as leukotrienes, platelet activating factors, substance P, serotonin, and acetylcholine may also be involved. The mechanism of induction of tolerance using wavelength that the patient can tolerate, such as narrowband UVB, is by immunosuppression, stratum corneum thickening, and pigmentation. Pathology. Within minutes of irradiation, a cutaneous perivascular infiltrate of neutrophils, eosinophils, and mast cells occur, followed by swelling of endothelial cells of dermal vessels and dermal edema. Clinical features. Onset of solar urticaria is typically sudden and clearly recalled. More than 63% have perennial symptoms due to UVA and visible light. Itch, burning sensation, erythema, and wheals typically occur within second to minute of exposure. Any photo-exposed site can be affected, and sparing under layered clothes, watches, and footwear. Most patients, that is 83%, will also be troubled with solar urticaria triggered by UVA and visible light transmitted through the window glass. Hardening is not typically reported in solar urticaria. In most patients, the urticarial lesions resolve within 2 hours, although a degree of abnormal erythema at exposed site may persist for 24 hours. Triggering of solar urticaria in patients have large area exposed result in systemic symptoms of malaise, headache, photophobia, wheeze, nausea, dizziness, and rarely hypotension and anaphylaxis. Exacerbation by low energy compact fluorescent source and rarely infrared radiation may occur. Clinical variants. There are infrequent reports of delayed onset and more persistent solar urticaria. There are also reports of solar urticaria occurring only at fixed reproducible sites or sites of bruising. Solar angioedema have been reported and appear to be a variant of solar urticaria. Differential diagnosis. The exclusion of solar urticaria secondary to drugs like tetracycline, fluoroquinolone, chlorpromazine, and some NSAIDs, notably venoxaprofen, which is no longer available, Riprenest, topical tar, pitch, and some sunscreens such as benzophenones. Porphyria, both erythropoietic protoporphyria or Porphyria cutanea tarda, particularly if there is photosensitivity at 430 to 460 nanometer, and lupus. So heat-induced urticarial lesions must also be considered among the differentials. Comorbidity and disease course. Anxiety and depression can occur with solar urticaria. Patient may have other urticarias, particularly physical urticarias. Contact or photocontact sunscreen allergy may occur. Idiopathic solar urticaria is a chronic disease in majority of cases, and there is chances of disease resolution from 12 to 36% by 5 years. Investigations. Monochromator photo testing is investigation of choice. Erythema, edema, wheal, and flare will occur within minutes at the photo test site and will resolve over an hour or so, often with associated delayed abnormal erythema at 24 hours. Most patients have fairly broad action spectrum for abnormal immediate photosensitivity with longer UVA and shorter visible wavelengths. Detailed knowledge of wavelength depends on the photosensitivity is critical for patient management and monitoring of response. Management. Photoprotection alone is usually inadequate unless symptoms are mild, but is nevertheless important. Behavioral sun avoidance and use of layered, tightly woven dark clothing and broad-brimmed hats is advised. Window film may be useful at home, work, and car windows. Attention to dietary vitamin D intake. Majority of patients gain some benefit from broad-spectrum high protection factor sunscreens. First line, 1/3 of the patient respond completely, with 1/3 partially to non-sedating H1 antihistamine, with the remainder having no response. Addition of H2 antagonist may provide additional help. Second line drugs include doxepin, ketotifen, chromoglycolate, montelukast. It may be possible to undertake desensitization using natural or artificial light, and this will be determined by the wavelength dependency and severity of photosensitivity. Phototherapy, if it can be tolerated, can be beneficial. UVA rush hardening using frequent subarticarial trigger broadband UV exposure, usually several times per day. Following a course of desensitization, some natural daylight exposure is required to prolong the tolerance. Third line agents include for severe recalcitrant disease, which has been used in single case or small case series, cyclosporin, systemic glucocorticoids, and other immunosuppressives are considered. Beta-carotene and hydroxychloroquine are unlikely to be effective. Intravenous immunoglobulin may be effective in some patients. For severely affected patients, plasmapheresis may be beneficial. More recently, anti-IgE monoclonal antibody omalizumab have been reported to be effective. Oral plypodium, leucotomus, and alpha melanocyte stimulating hormone analog are used experimentally in small number but require further studies. So the sixth and the last of the primary immunological photosensitivity diseases is HYDROA vacciniforme. It's a rare acquired photodermatitis that usually present in first decade of life and is typified by the development of vesicles, crusting, often hemorrhagic, and subsequent verruliform scars on photoexposed sites. HV is rare and estimated prevalence to be 0.34 cases per 100,000 population. It has a bimodal age distribution, onset between 1 to 7 years or 12 to 16 years. Both sexes are equally affected and occur in all races. Etiology of HV is unknown. UVA wavelengths are implicated in the provocation of lesions, which are induced either in spring or summer sunlight or by artificial ultraviolet light. Role of Epstein-Barr virus infection have been proposed. HYDROA vacciniforme-like presentation is reported in aggressive form of T-cell lymphoma in children, which may be associated with human Epstein-Barr virus infection. An association with HLA-DR tissue typing is suggested. Biopsy of a lesion may show non-specific histology with reticulate keratinocyte degeneration, spongiosis, and perivascular inflammatory infiltrate consisting of lymphocytes, histocytes, and neutrophils. Lesional histology a few days later is of ulceration, epidermal necrosis, papillary edema, and upper dermal necrosis and subsequent scarring. Direct immunofluorescence is negative. Clinical features. Patients typically present with seasonal symptoms in spring and summer. Following 15 minutes to few hours of direct or window glass transmitted light, intensely pruritic crops of papules and vesicles, often arising on background of erythema and edema, occur on exposed sites within 12 to 24 hours. A burning sensation and pain may occur. Vesical fluids often become hemorrhagic, and there may be systemic malaise and fever during the acute episode. Commonest sites are cheek, nose, ear, and back of hands. As the vesicle resolve, hemorrhagic crusting develop, and as this detaches, verruliform scars remain that can be severe. There may rarely be cartilage destruction, for example, of ear, nose, and contracture of digits. Eyes can be affected with photophobia, conjunctivitis, keratitis, anterior uveitis, corneal clouding, and neovascularization, scarring, and visual impairment. So you can see the crusted lesions and scarring in these pictures. Differential diagnoses include bullous lupus erythematosus, EPP, Hartnup disease, and T-cell lymphoma if children is otherwise unwell. Complication and comorbidity, there can be significant scarring, ocular complication, and rarely cartilage destruction. Disease course and prognosis, usually the condition improves and resolves in later teenage years with mean duration of disease 9 years. Investigation, full blood count, anti-nuclear antibody, acceptable nuclear antigens, porphyrin biochemistry should be undertaken. Urinary amino acid may also be requested. All these investigations are normal in HYDROA vacciniforme. Monochromator photo testing may be normal or more typically show predominantly UVA sensitivity. Negative photoprovocation with artificial source is suggested to be a good prognostic factor. So the management, photoprotection by behavioral modification and use of clothing, hats, sunglasses, UVA absorbing window film, broad spectrum, high SPF sunscreen are all important. Dietary vitamin D should be optimized. Psychological support is required. First line is photoprotection and topical corticosteroid in active disease. Second line, springtime desensitization with narrowband UVB phototherapy is successful in 60%. PUVA is less often used. Third line is oral glucocorticoids, beta-carotene, azathioprine, cyclosporin, and anti-malaria. Although their benefits are unproven, thalidomide appears to be ineffective. So this table I deliberately placed here to highlight you the importance of understanding the solar or ultraviolet spectrum of these primary photodermatitis. So in polymorphic light eruption, it is mainly the sunlight, and 1/3 of the cases UVA and UVB. Same is the case with juvenile spring eruption. But in actinic prurigo, it is mainly UVA and UVB, and the sunlight does not have much role. In chronic actinic dermatitis, the main spectrum is UVB. In solar urticaria, it is mainly UVA and short visible light. And in HYDROA vacciniforme, it is UVA. Exogenous drugs and chemical-induced photosensitivity. They are subdivided according to whether the drug or chemical is administered systemically or topically. Drug and chemical-induced photosensitivity may have diverse presentation, although phototoxic or exaggerated sunburn is the most common finding. Drug phototoxicity can theoretically occur in anyone and on first exposure, although idiosyncratic and probably genetic factors exist. It is reversible if drug exposure is stopped. Older patients whose polypharmacy include many photoactive drugs are more at risk. Gender does not appear to have an effect, nor is the race and skin phenotype. Pathophysiology. There are several mechanisms of drug and chemical-induced photosensitivity, and most require oxygen, resulting in toxic photosensitizers. Most systemic drug photosensitivity is phototoxic and non-immunological. Drug and chemicals applied topically may also cause phototoxicity. Other less common mechanisms include pseudoporphyria, drug-induced lupus, lacinoid reaction, EM, pellagra, and photoallergy. Photoallergy is most frequently seen with topical sunscreen, NSAIDs, and less common with certain fragrances. Sunscreens are the commonest topical photoallergens. Topical phototoxicity can occur with dye stuff and sorrelin-containing plant, which is called as a phytophotodermatitis. Pathology. The histological picture of phototoxic reaction is of epidermal necrosis, apoptotic keratinocytes, and mild inflammation. Spongiotic dermatitis occur in photoallergic conditions and is usually due to topical agents. Clinical features. The symptoms of drug phototoxicity are usually an immediate burning sensation on sun-exposed sites, often with erythema and sometimes urticaria. Sometimes delayed erythema and blistering occur. Sorrelin produce a delayed erythema that is peaking at about 72 to 120 hours after exposure. Patterns of drug-induced photosensitivity. Immediate burning, pricking, or subsequent pigmentation. It occurs due to amiodarone, chlorpromazine, photofrin, Foscan, topical tar, and pitches. Exaggerated sunburn occur due to thiazides, fluoroquinolone, quinine, tetracycline, amiodarone, and chlorpromazine. Delayed erythema and pigmentation is seen with sorrelin. Pseudoporphyria occurs due to NSAID, particularly naproxen, diclofenac, and piroxicam, furosemide, naldixic acid, tetracycline, fluoroquinolone, and retinoids. Drug-induced lupus occur because of hydralazine, thiazides, and proton pump inhibitors. Lacinoid drug eruption occur because of thiazides and NSAIDs. Photodisturbed purpura, levofloxacin, pellagra, isoniazide, and phenytoin. Drug-induced photodistributed telangiectasias and angiomas by calcium antagonist and venlafaxine. Photoonycholysis, doxycycline, and sorrelin. Acneiform eruption on photoexposed sites, amiodarone. Topical drugs and chemical photosensitization. Tar, pitches, plant dyes, NSAID, fragrance, halogenated salicylate for phenothiazines and sunscreens. Phototoxic reactions. Contact with sorrelin-containing saps of umbelliferae and rutici plant and subsequent UVA exposure. This is in linear and angular configuration within 48 to 72 hours, which is phytophotodermatitis. Other clinical patterns like strimmer dermatitis or Burlock dermatitis also occur because of phytophotocontact dermatitis. Organic sunscreen chemicals, fragrances, and NSAIDs can cause both photoallergic and phototoxic reactions. This is a phototoxic reaction. Prolonged pigmentation can occur after systemic or topical drug and chemical-induced phototoxicity. For example, linear streaks of hyperpigmentation often persist for months after episode of phytophotodermatitis. Reticulate hyperpigmentation is reported with photosensitivity due to calcium antagonist deltaism. Leukomelanoderma may occur in particularly after thiazides or quinine phototoxicity and appear to be due to dysfunction of melanocytes. Chlorpromazine and amiodarone photosensitivity are often complicated by prolonged pigmentation. Differential diagnosis of drug-induced photodermatitis include chronic actinic dermatitis, porphyria cutanea tarda or variegate porphyria, lupus erythematosus, idiopathic solar urticaria, and cutaneous T-cell lymphoma if it is erythroderma. Complications and comorbidities. Association between photosensitivity drugs, use and risk of squamous cell carcinoma and basal cell carcinoma and melanoma. Abnormal lentigens and increased SCC and melanoma have been observed in patients taking photoactive drugs or voriconazole. The skin tumors are induced in mice exposed to fluoroquinolones and light. Photosensitivity is reported in patients receiving BRAF inhibitor for melanoma, and these patients are at markedly increased risk of developing SCC. A time course for resolution of photosensitivity of the drug will depend on the bioavailability and half-life of any photoactive metabolite. Sorrel photosensitivity clear within a few hours, fluoroquinolone and chrompromazine within 48 hours. Thiazide photosensitivity may last 3 to 6 months. Systemic sorrelin used for photodynamic therapy can still be detectable at 3 months. Quinine photosensitivity lasts for several months, and amiodarone effect lasts for an year or more after stopping the drug. Skin fragility may persist for months, and pigmentation and telangiectasias can remain for longer. Investigations. Monochromator photo testing should be undertaken. Most photoactive drugs have maximal absorption at UVA wavelengths. Some drugs like quinine and thiazides have extension into UVB region. Fluoroquinolone and systemic porphyrin drugs used in PDT causes visible light photosensitivity. Photo patch testing is investigation of choice for suspected topical photocontact allergy, but it is not reliable for investigating systemic drug photosensitivity. Management. Recognition of the diagnosis and cessation of suspected drug or chemical is essential. If in doubt, a suspected drug should be stopped and photo testing repeated at interval of the drug. If drug cannot be stopped, then dose reduction should be advised. Photo protection, including broad spectrum and reflectant sunscreens. First line is, of course, stop the drug, improve photo protection, and initiate symptomatic treatment with emollients and topical corticosteroid. Second line, if a drug such as amiodarone cannot be stopped, induction of tolerance by using narrowband UVB or PUA may be helpful. Then the second last topic of today is the photoaggravated dermatosis. There are a range of skin diseases that are aggravated or exacerbated by natural or artificial ultraviolet or visible radiations. These conditions are heterogeneous, for example, psoriasis and eczema, which can be atopic, seborrheic, or allergic, that often improves with sun exposure, but in minority, approximately 10% or less, there is worsening of dermatosis with sun exposure. In other photoaggravated conditions like bullous pemphigoid, dermatomyositis, or cutaneous lupus, photoprotection and treatment of underlying disorder are the mainstay approach of management of these conditions. Other photoaggravated dermatoses include acne vulgaris, rosacea and facial telangiectasias, herpes simplex and other viral exanthem, erythema multiforme, Jessner's lymphocytic infiltrate or LE tumitis, lymphocytoma cutis, pemphigus or hele linear IgA dermatitis herpetiformis, diarrhea and transient encapsulated dermatosis, disseminated superficial actinic porokeratosis, pellagra, mycosis fungoides. Of course, melasma and vitiligo, PRP, reticulate erythematous mucinosis, urticaria, actinic granuloma, keratosis pilaris, and Sweet syndrome. So the last topic of today is the clinical assessment and management of a patient with suspected photosensitivity. although we discussed this in detail in various diseases, but to summarize, we have to take a detailed history, and examination is essential. For many patients, relationship with sunlight is clear, particularly if only affected in spring and summer season and on sun-exposed sites like in polymorphic light eruption. The important information include age at the disease onset and duration of the disease, the gender, presence of atopy, occupation and hobbies, family history, drug or chemical use, systemic and topical. Some conditions are more likely to present in childhood, such as xeroderma pigmentosa, erythropoietic protoporphyria, actinic prurigo, HYDROA vacciniforme, whereas chronic actinic dermatitis is more likely in older males. It is important to know whether the photodermatitis is perennial or seasonal, and what is the type and duration of exposure, that is by direct sunlight, by window glass transmitted light, artificial internal light, sunbed exposure, or comorbids, or combination. The duration of time from the triggering exposure to occurrence of eruption, that is the latent period, is also helpful in diagnosis. The time course of eruption, when it peaks and how long it takes to resolve. For example, typically polymorphic light eruption take a few hours of exposure to trigger, and rash lasts rash later that day, occur later that day, peaking the next day and resolve in 2 to 3 days. In contrast, solar urticaria occur within few minutes and on exposed site and resolve within an hour. It is important to determine whether there is hardening, that is the rash being less likely to occur on habitually exposed sites of face and back of hands, and less easy to provoke in later summer as seen in polymorphic light eruption. Symptoms are also important. Pruritus occur in many photodermatoses such as polymorphic light eruption and chronic actinic dermatitis. Pain or burning on sun exposure arise the possibility of EPP or drug photosensitivity. Can it occur through clothing as in solar urticaria? Morphology of rash is important. Like papillovesicular rash is seen in polymorphic light eruption, urticarial wheals in solar urticaria, hemorrhagic vesicles and crust in HYDROA vacciniforme, scarring occur in HYDROA vacciniforme, actinic prurigo and EPP. Exaggerated sunburn erythema occur in drug photosensitivity. Delayed peak at 2 to 3 days or later. Sparing may occur in shadows cast by sideburns, spectacles, hairline, deep skin creases on the forehead, under the nose, chin, lower lip, behind the ears, Wilkinson triangle, and on the upper eyelids. So these are the areas of sparing. Dorsa of hand and feet and extensive surface of limbs may also be involved. If covered side are affected, this is usually due to a lesser extent. There is fragility as seen in porphyria cutanea tarda or pseudoporphyria. Cheilitis and conjunctivitis is seen in actinic prurigo. The investigations usually undertaken will be tailored to the patient's presentation and suspected diagnosis. Mainstay investigation is monochromator photo testing, which employs a filtered high-pressure xenon arc lamp to deliver relatively monochromatic ultraviolet and visible light across the solar spectrum at very precise dose ranges to skin on the back. Immediate and delayed erythemal response are assessed based on minimum erythema dose at each wavelength. Minimum erythema dose below the normal range indicate abnormal photosensitivity. Morphology of photo testing response is important. For example, in chronic actinic dermatitis, it becomes eczematous. If phototherapy is to be considered, it is always recommended that minimum erythema dose for a light source, that is narrowband UVB, is determined to exclude abnormal photosensitivity. If patient has an eczematous eruption or is suspected to have a contact allergic dermatitis, then patch or photo patch testing should be undertaken. Patch testing is essential investigation for patients with chronic actinic dermatitis. Photopatch testing is taken using standardized European methodology. The commonest photoallergens are sunscreen and lesser extent NSAIDs. In photopatch testing, a duplicate series of photoallergens are applied on the back. One set is irradiated with a typical ultraviolet light at 24 to 48 hours later with suberythemal UVA dose, and the reading is again taken after 2 days. In practice, this investigation may be difficult to perform and interpret. A patient is severely photosensitive, but it should be undertaken if possible. Exclusion of lupus is important in serology for anti-nuclear factor, and ENA like Rho and La should be taken. When indicated, porphyria should be excluded. If AP is suspected, HLA typing should be done. Histology of an existing or provoked rash may be informative, for example, HYDROA VACCINIFORME, but rarely diagnostic. In genophotodermatosis, it is necessary that skin and blood samples should be taken for DNA repair activity and genetic studies. Patient on strict photoprotection, vitamin D level should be measured and replacement advised. Management of patient with photosensitivity rests on establishing the correct diagnosis. General approaches to photoprotection apply when emphasis on behavioral modification, seeking out shades, and avoid direct sun exposure between 11 a.m. and 3 p.m. Covering up with tightly woven dark and if necessary layered clothing, and wearing hat with wide brims is beneficial. Regular and liberal use of broad spectrum high factor sunscreen applied every 2 to 3 hours is advised. In practice, sunscreen offer 25 to 33% of protection. In particular, advice on sunscreen should be tailored to the nature of abnormal photosensitivity. If patient has visible light sensitivity such as solar urticaria or chronic actinic dermatitis or cutaneous porphyria, addition use of reflectant sunscreen is recommended. UV blocking window film DermaGuard that absorb ultraviolet radiations can be applied to car windows and at home or at work. Major adverse impact of photosensitivity on quality of life, particularly chronic and severe, should not be underestimated, and psychological support may be required. In general, management is subdivided into prevention and treatment, with prevention being the main goal. Active dose disease should be treated with conventional way using topical glucocorticoids. Photochemotherapy may be used in attempt to induce tolerance, and most commonly used for idiopathic or immunological photodermatosis like polymorphic light eruption, while it can be used in other disorders as well. Systemic therapies, often with immunosuppressants or immunomodulatory agents, may be required in severe diseases. That's all for today, and I hope to see you next week with another edition of my lecture. So, thank you very much and goodbye.